Bismillahirrahmanirrahim. The first topic of vascular pathology is atherosclerosis. So, atherosclerosis means localized fibrous thickening of large and medium sized arteries. It is typically characterized by the formation of plaques within the arterial wall known as atheroma. This is the cut section of the artery. This is the lumen of the artery, and this here is the atheromatous plaque. The atheromatous plaque results in the narrowing of the artery, hence resulting in the mechanical obstruction. Moreover, this atheromatous plaque can also often rupture, releasing its contents into the arterial lumen, causing thrombosis and embolism, which also leads to mechanical obstruction. The ultimate result of the blood flow obstruction is ischemia to the end organ. Atherosclerosis constitutes almost 50% of all deaths in the West. Since the outcome of atherosclerosis can result in myocardial infarction, stroke, acute and chronic limb ischemia, and it can often result in obstruction to the renal artery. The risk factors of atherosclerosis can be classified into modifiable risk factors, which can be either reduced or enhanced by the patient himself. The modifiable risk factors include hyperlipidemia, more particularly excessive LDL levels in the blood. Hypertension also results in turbulent blood flow, causing endothelial damage and progression in the formation of atherosclerosis. Smoking is a known risk factor of myocardial infarction and stroke, which not only increases the LDL levels, but the toxic chemicals also damage the endothelium of blood vessels, hence resulting in the atherosclerosis. Diabetes induces hypercholesterolemia and hypercoagulable state. Both hypercholesterolemia and hypercoagulable state result in the atherosclerosis. The non-modifiable risk factors include age between 40 to 60 years, and males are more dominantly affected rather than the females. The estrogens present in the females have a protective role in the formation of atherosclerosis. Moreover, family history and genetic predisposition is also of key importance, since the disease most commonly affects the first-degree relatives. The other risk factors for formation of atherosclerosis include dietary factors, a sedentary lifestyle or lack of exercise, and certain personality traits such as stress can also increase the incidence of atherosclerosis. The pathogenesis of atherosclerosis is rather complex, and it takes almost 20 to 40 years to develop into complete atheromatous plaque. The first incident in the development of the disease is endothelial injury. The injury to endothelium results in leukocytes adhesion, increased permeability of endothelium, and thrombosis. So the damaged endothelial cells first of all release certain inflammatory mediators which recruit inflammatory cells such as monocytes and lymphocytes to the site, and these inflammatory cells attach to the damaged endothelial cells through a specific protein known as vascular cell associated molecule 1, or simply VCAM1. This VCAM1 protein is recognized by the monocytes, and it causes the adhesion of mononuclear cells to the endothelium. So this is a damaged endothelium which releases the inflammatory mediators, resulting in the recruitment of monocytes and lymphocytes which attach to the endothelial cells. So these monocytes diffuse through the endothelium into subendothelial space, and once the monocytes reach the subendothelial space, they transform into macrophages. This is the first step of formation of atherosclerosis, and this typically occurs within the first or second decade of life. The next process is the diffusion of cholesterol, specifically small-sized LDLs, into the intima. The LDL in this case is oxidized, which is recognized by the scavenger receptors present on the macrophages. These receptors regulate the uptake of cholesterol by the macrophages and convert into foam cells. This formation of foam cells appear as fatty streaks on gross examination. The oxidized LDL present inside the foam cells also damages these cells, resulting in their necrosis. These necrotic foam cells release cytokines, which recruits more monocytes and lymphocytes to the site, and hence a vicious circle of inflammation starts. The necrosis of foam cells also releases fat inside the subepithelium, resulting in formation of a fatty core. There is also aggregation of T lymphocytes and platelets within these atheromatous plaques, which release certain growth factors such as platelets-derived growth factors and transforming growth factors, which recruit the smooth muscle cells. This recruitment of smooth muscle cells could be either from the media or it could be the precursor smooth muscle cells present in the blood. These smooth muscle cells form a layer beneath the endothelium, and moreover they also secrete extracellular matrix, hence forming a cap of smooth muscle cells and connective tissues. This cap is also known as fibrotic cap. Hence a complete atheromatous plaque is formed, which is typically composed of a fibrotic cap, a lipid core, foam cells, macrophages and lymphocytes. So a quick recap. First of all, there is an endothelial injury, and the damaged endothelial cells release cytokines, which recruit inflammatory cells, particularly monocytes, which attach to the endothelium and they diffuse through the endothelium into subendothelium. So these monocytes, once reach the subendothelium, convert into macrophages, and these macrophages, by means of scavenger receptors, uptake LDLs, hence converting into foam cells. These foam cells undergo necrosis, releasing cytokines and growth factors and fat inside the core of atheromatous plaque. These cytokines and growth factors recruit more inflammatory cells and proliferate smooth muscle cells. These smooth muscle cells migrate below the endothelium and form fibrotic cap. Moreover, cholesterol also diffuses through the endothelium into subendothelial space and results in the formation of a lipid core. So an atheromatous plaque is composed of, first of all, there is endothelial layer, below which there is smooth muscle cells and extracellular matrix forming fibrotic cap of atherosclerosis. Then there are inflammatory cells present at the shoulder of the plaque, and present at the centralized location there is a core of cholesterol. So grossly, an atheromatous plaque appears whitish to yellowish colored mass, as you can see here. And in certain cases, a ruptured atheromatous plaque appears to be red or brownish colored. This is a brownish colored ulcer which is formed as a result of atheromatous plaque rupture. The size typically ranges from 0.3 to 1.5 centimeters, and it affects only large to medium-sized arteries. The cut section reveals eccentric lesion present in the arterial wall due to smooth muscle cells proliferation. And the cut section surface appears to be yellowish, which is due to excessive fat deposition. Coming on towards the histological picture of the atheromatous plaque, there are three principal components of the erythroma. The first is the cellular component, which is composed of macrophages and foam cells, smooth muscle cells, and often T lymphocytes are also present. The second component is the extracellular matrix, which is formed by the deposition of excessive collagen, elastin fibers, and proteoglycans. The third component is the presence of intracellular as well as extracellular lipid deposits. So this is the lumen of an artery, and this is a fibrous cap. This fibrous cap is formed of smooth muscle cells and extracellular matrix. At the shoulders of the atheromatous plaque, there are inflammatory cells such as T lymphocytes, macrophages, and proliferating smooth muscle cells are also present. Moreover, there is a core of atheromatous plaque which is composed of excessive lipid and necrotic cell debris. The necrotic cells are mostly the macrophages and foam cells. In certain advanced and rare cases, the calcification of atheromatous plaque also occurs, which result in the stiffening of the arterial segment. According to American Heart Association, atherosclerosis is further divided into 6 types. Each type also indicates the progression of atherosclerotic plaque. Type 1 is indicated by the presence of macrophages and foam cells within the walls of arteries, which further progress into type 2 atherosclerosis. In type 2 atherosclerosis, there is formation of foam cells as well as intracellular lipid accumulation. As you can see here, there are small lipid particles accumulating inside the atheromatous plaque. Type 1 and type 2 atherosclerosis typically occur in either first or second decade of life, and it is also characterized by the presence of fatty streaks. Type 3 atherosclerosis is characterized by the presence of foam cells and extracellular lipid pools. As you can see, there are lipid pools present inside the atheroma. Type 4 is the formation of a large core of lipids. This is a large lipid core which contains low density lipoproteins as well as certain necrotic macrophages. The type 3 and type 4 atherosclerosis occurs in almost third decade of the life. Type 5 atherosclerosis is characterized by the presence of lipid core, foam cells and lymphocytes, as well as there is a fibrotic cap formed over the atheromatous plaque. This is a fibrotic cap which is composed of smooth muscle cells and extracellular matrix. And this fibrotic cap is formed in almost fourth decade of the life. Type 6 atherosclerosis is characterized by the development of a complication which is characterized by the surface defects, formation of thrombus, and hemorrhage of the plaque. This is a hemorrhagic area of an atherosclerotic plaque, and this complication occurs in almost fifth or sixth decade of the life. The atherosclerotic plaques are typically formed in large or medium-sized arteries. And the most common site of atherosclerosis is abdominal aorta, coronary arteries, which ultimately lead to myocardial infarction. Popliteal artery is present behind the knee in the popliteal fossa, and atherosclerotic plaques within the internal carotid artery and circle of Willis arteries are also present. The most common artery affected by the atherosclerosis is middle cerebral artery, causing ischemic stroke. The atherosclerosis causes mechanical obstruction by narrowing the lumen of the artery, hence resulting in the ischemia of end organ, such as myocardial infarction, stroke, and limb ischemia. Moreover, the atherosclerotic plaque can often rupture, which releases the lipids, cytokines, and inflammatory cells into the blood, which are highly thrombogenic, hence can result in either complete or partial obstruction to the blood flow, causing ischemic injury. The lipids released as a result of the rupture can also lodge inside the small arteries, resulting in atheroembolism. Atherosclerosis is associated with the weakening of the vessel wall, hence resulting in the formation of outpouchings known as aneurysms. The aneurysms can develop in the thoracic aorta, in abdominal aorta, and in the circle of Willis. These aneurysms can ultimately rupture, leading to profuse bleeding and shock. The hemorrhages can occur within the plaque as well as inside the blood vessel. The hemorrhage usually occurs within the plaque at the site of neovascularization, leading to bleed within the atherosclerotic plaque. So this concludes our discussion about atherosclerosis. Thank you.